Okay. All right, so that's cleaned out, I think. Yep. So, so we have a patient with gastroparesis, secondary to long-standing diabetes. We have taken the patient for G-POEM. All right, so we cleaned out the stomach, and let's see. Let's get a nice view. Actually, you know what? Give them a mic also if they want to, put one. If you want to ask questions on that, you can apply one. Give me a gauze now, wet gauze. Right. So with GPOM, you know, you can have a lesser curve approach, which is going from here, where my water jet is, right? A greater curve approach, which is sort of the standard one, okay, which most of us do. I don't do lesser curve, but I haven't really tried it, but maybe one of these days, if required. Because by and large, your posterior along the greater curvature works fine. And the difference in G-POEM versus E-POEM is the myotomy is limited. So you don't do a very long myotomy. That's the other. Put some air, let's distend it. Let's see. Yeah, okay, nice. That's cool. So, because of that, you don't really need to make a long tunnel. A short tunnel will usually take care of it. Yeah. It's not too bad. It's a little whitish. Could be intestinal metaplasia. With those whitish patches typically. Do a little magnified views. Those.
The pitch
see the light blue crest.
Yeah.
You see, there's that light bluish appearance, and that's intestinal metaplasia, which you can see more.
The pitch pattern and the vascular pattern
we'll ideally need it like
regular.
Yeah. So you're right. That's intestinal metaplasia there. Let me take care of it. All right, cool. All right. So here we are, and let's see. Okay. So what we do is maybe start somewhere here, right? Because you have to tunnel till there and cut till there. So this much should be sufficient. All right. Let's see. You want to make sure that you don't have wrong and sort of access as you enter, because you make a mess of it, and you go on the side, you will not, you'll miss the angle. Let me rephrase this. If you go from here and you want to go straight, you want to hit the pylorus. If you go on the side, then you go this way, then you're going to keep circling around the pylorus, and that can be a mess. It has happened to me. I was doing a live demonstration of G-POEM, and exactly then it had to happen.
And what did you do?
We then reoriented ourselves and found the pylorus. Okay, I'm going to wait. Right, because you have to wait so that your alignment is right, which is looking fine here, right? So I go here, I think it'll be okay. Out.
So do you always give something
Inject?
like Buscopan or
Yeah, I mean, if it's too much, then we will give, right? The movement is a lot, then yeah. There's a lot of contraction right now, yeah. Stop back. Yeah, okay. Fine. Quick. Nice.
Do you find G-POEM more challenging technically or less challenging?
No, not really. I mean, there's some issues with blood vessels, Blood vessels can be a bit of a problem in G-POEM, but that's okay. Let me see. Hold it. Hold scope. Yeah, the blood vessels can be a bit of a problem with G-poem. Okay. All right, good. Hold scope now. Out. Okay. See the muscle right there. Okay. Out. Yeah. All right. Okay. Look at this. Inject here. Okay. Stop. Out. Yeah, pulling is a little bit of a challenge in this also. As, hold here. Out. Back. I think I may have to talk a little more. Yeah. Okay. Give me. I mean, we are far, so we are okay. Okay. Out. Out. Yeah. Better. Out. Back.
Will that taper tip cast help?
Yeah, I mean, it depends. I mean, here, unfortunately, it's not as good a lift as I would have liked. I'm going to put some more injection here. Yeah, inject here. Be a little more dissection, and then we'll go in. I think it should not be a problem. Stop. Out. side sit. Back. Maybe a little bit of lateral dissection was required. I think I have to do a little base and lateral dissection. That's probably why. Inject. Yeah, good point. Stop. Yeah, supine, yes, it's cooling. That's a bit of an annoying problem out. Positioning is primarily an issue when it comes to, pooling of fluids, which, yes, now is a bit of a problem. Okay, hold it out. This edge is a little more challenging to get it to. Should actually make a difference. That a little bit of dissection there. Okay. One more attempt now. Look at again the distal part. Okay, out. Yeah, all right, okay. Now it's standard tunneling, okay? Okay. So I'm going to attempt to do a standard sort of gentle out. Just to so now the positioning has a little less role, right? Because pooling is not as much of a problem. See? All right, so this is a little bit of a larger vessel out. So now I'm going to use a coag grasper in this case. Out. This happens with gastric side, they just have bigger vessels. Back. Coag grasper. Open. Yeah, you see me. I mean, the kind of size here is much bigger than esophagus, right? Those soft coag being Give me soft coag here. Open, close, open, close, open, close. Okay, going. Can you move this a little here and fix the camera also? Yeah. Tell him you are out. So the way is to slowly, steadily coagulate the vessels, and then this was large. Yeah, just move it here. Yes, move the camera also. That's fine. Yeah, it's okay. All right. Okay. I almost feel like I'm reaching, but that's fine. This feels like pylorus almost. Let's see. You know. Back. Oh. No. Let's see, this is the thing. Now we entered here, and then we have to go straight. Okay, fine. Who's from this? Out. Okay. So you want to let it cook slowly, the vessel, as opposed to zip, zip, zip dissection, and then in that case, you're going to cause a problem. All right, okay, nice. Close. Inject here. Okay, stop. Out.
What is the length of anatomy of this?
About a centimeter. Yeah. Not very long. Yeah, I'm going to use a coagulant. I'm not taking chances. I don't like this. Quite raspa.
What do you think of the
Yeah.
technique of those feeding vessels instead of using the coagulant?
Which one? The coagulation technique, right?
Yeah. We put the knife on the two sides.
That's true, but I think this is large.
Yeah.
I don't know. Okay, open. It's fine, but these are really large vessels. The smaller ones I'm comfortable with, and then you're doing it, and then it starts bleeding, and it's a problem. Then open. It's just a mess. Yeah, close. So standard stuff, yeah, open. Esophageal poem for the most part, yeah, close. Certainly you can do it. I'm sort of changing my technique slowly. So these are the ones I'm not going to attempt. We'll start with relatively smaller ones, and then go for these ones if I'm really comfortable. Out. Okay. It's a little bit on the left, so So esophagus is a little in that sense that scope movement is very straight. Here can be a little off. Movement is not exactly very straight sometimes. So yeah. Now she's looping, the scope's looping in the stomach, right? So that's the one challenge that you encounter. It's not 1:1. See, I've pulled out the entire scope and then out to remove it by half a centimeter. The same problem happens when you're doing a diurnal NET. It's a loop in the stomach which can be a little annoying. Back. You see now where have we reached? We have reached till about here. Maybe another centimeter and then we should be okay. See now it seems more right. Huh? Look at this. Usually, maybe I would have wanted it a little bit on this side. Ultimately, slight laterally. Half a centimeter. Okay. Okay. Inject here. Put her a little bit on this side. It's okay. Yeah. Screen comes so movement is a bit. Okay, fine. Stop here. So lateral dissection is always annoying, So as far as possible, just make sure that your angles are fine. This was not too bad, so I could have not much of a problem correcting it. But if you have too much of a problem, then the direction is just on the side, and it can be real painful. Exercise to go lateral. Back. Good. Stop. The other difference is you can't do any measurements, right? I mean, at how many centimeters? Because the scope tends to loop, so that can affect your ability to have accurate measurements of the length. Like sigmoid, esophagus. Okay. Okay. Back. Like that.
How do you know when you have arrived at the pilot?
You will know.
In the E-poem, you usually look for measurements, don't come out of the tunnel.
Yeah, open. You'll see a ring open, concentric ring. Close. Open. Close. So you have to keep checking where you are. So come out of the tunnel, take a look, and go back in. Inject. Stop. Inject. Out. Wow. A lot. Close, inject. Stop. Let's come and see where we are. I hope I'm not going very laterally. 1 and 2. Ha, okay. Yeah. So we're in the vicinity. I think we maybe. Yeah, it somehow seems so much lateral now. When I started, it looked okay. All right, but fine. We go here, go here. Go. This is not a pacifier. It's somehow gone more. Yeah, okay. So we need to correct it and go a little more straight. Yeah, I think I need to go a little this side. Somehow, in an attempt to correct it, I think I've done little over correction by going on the left. So let's take care of this part. Out. Out. Do this.
Think of injecting concentrated methylene blue at the spot that we would like to.
No, no injection. Don't want to cause problem. I mean, it's okay. We know how to find it, so we should be okay. I wouldn't do any of that. No. Back, inject here. You saw that I was going a little left, and then I think I realized my direction was not ideal. Instead of going there, I want to just go sort of here now, inject. It's why important to keep checking, because sometimes you feel like you started right and it's going okay. You know, the subtle movement issues can cause problems. Stop. Yeah. Close. Inject here. Stop. Out. Yeah, I think I need to get rid of this before I grasp. Cause any. Okay. Open. Close. Open. Close. Open. Close. Okay. Out. Close. Inject here. Stop. Out. I feel like I'm there. You see that? Back. Yeah, right. Yeah, that's the one. Because that's the duodenal mucosa at the far end. And this we have, I'm pretty sure we have reached, but we'll check again. This at 6 o'clock is your pyloric ring. Okay. There's a little bit of fibrosis, so get rid of this. Yeah, this is it. Okay. Now, yeah, inject here. So inject there to see the duodenal side and see how the, how the injection looks like. Okay. I was actually not too far. I was here. I mean, we could have gone dissected there or here. So it seemed, it goes, sort of corroborates with what I was saying. Now you see this, yeah, this muscle here is looking different, right? I mean, versus muscle here. This is pyloric ring, and this is the antropyloric muscle here. This is white because of coagulation, not because, oh. Inject. Okay, lovely, stop. Now I'm pretty confident, but I'm going to go and check, of course. But I mean, at this point, you have to be extremely careful to not injure the duodenal mucosa. And I think I like to use an IT knife at this point for the myotomy back. Because you don't want to have any injury on the other side to the duodenal mucosa. And it's appropriate. Let's fix this. Out. Right. All right. Address it. We're there. Ready? Keep the IT knife ready. Maybe coag grasper to take care of that vessel, and then IT knife. Okay. Okay, here we go. We enter from here. On down there. Bulge. Right there. Okay. Grasper. Wait a second. No, it's okay. Give me IT, yes. So the key is that you have a good myotomy, not a very long myotomy, but a good full myotomy. That's the important part. So if something till here is good enough. We don't need to do much more. A little bit of dissection on the duodenal side does help. Slip here, man. Yep. And the most scary part are the vessels. So, let's see, okay. Yep. And vessels, especially on the muscular, intramuscular, and also on the serosal surface, which, as I said, I knew it. All right, wait what happened. This is always a challenge fact. And it's hard to know because it's all intermuscular, so you can't really predict it as well. Dissection, at least, you know, the arterioles with a jet speed flow. Open, close. Okay, so now I know that I had the right thing. Open, close. Small vessel. It's an arteriole, right? So that's, in fact, the larger ones, if they are venules, is less of a problem than the smaller arterioles, because finding that arteriole is one issue, and you know, and the speed at which the blood flows is obviously much higher. So those are the issues.
Is there any difference between poem of the both muscular, circular and longitudinal?
Yeah, mostly
opposed
people do
to-
full thickness. Yeah, the pylorus. Yeah. Yeah. Get a little bit more. Yeah, that's more than enough. Length is, I'd say that's at least a centimeter, right? Probably okay, looks to me. At the most, a little bit here, and that's it. Open. Longer is a problem also. So you don't want to do long, because antral hypomotility is a problem in these patients, right? So if you do a antral myotomy, that little bit of impetus from antrum is also gone. And here's the thing, that these large vessels at the bottom, and I believe I have got a full thickness here. So as part of me is always tempted to just do a little more, but that's the issue with those vessels. You want to be careful. Let's see. Okay, I think open. The feeling may be a little bit. Take it up this part here. Okay, so give me a TT knife. I'm going to go down up because there's not much space there. So that pyloric ring, I want to really make sure is well addressed, right? You agree? That part, no? I mean, this is okay. We can leave it alone here, it'll be fine. That pyloric ring is the thing to take care of. That one. But I, all right, okay. Go more out, then it's duodenum. So now it's looking better. Back. Inject. Excuse me. Stop. I think I should take care of that one too. Out. Out. Excuse me. Back. It's still pyloric muscle, I feel. I think so. I think I'm going to do a little bit. There is big vessels below it, so I have to be more careful. Yeah, out. Yeah, okay, better. And that will keep going. That's the duodenal side now, but this is fine, right? Avoid that part. Okay, this is a serosal, right? See, the longitudinal one is cut over there. See that? And now I think I would not want to touch the serosa. There's too many blood vessels there. Yeah. So we have full thickness here. From there, you see, at that end, come back. All these blood vessels is full thickness. And then you come. Yeah, come here. Full thickness. And then maybe, yeah, I think I don't want to do more. I think that should be enough. Yeah, okay. Now you see over there, that's the duodenal side of muscle, no? The one muscle you see over there, that's duodenal muscle over here. That's not pyloric. This here is pyloric, which is cut. This here, this white strap there at the far end, which is not cut, is duodenum. But the one before is all pyloric. Right? Out. Oh, you're very careful. You know exactly what you're cutting. You need to be careful. Yeah. I may just do a little more of this part for the heck of it. Yeah. Yeah. Out. It's true. Back. I'm not touching that part. What's that? Okay. Yeah, I think I'm going to see it once now. This is the problem. I think I've made a mucosotomy there. I knew it. It's okay. We'll put a clip there. But that's one thing to be careful of. Doing that little extra bit. Hold it. Examine it. Okay. You see now, pylorus. This has been cut. More open. Yeah. You see the depression. This is the muscle that's been cut. This point over here, you see this point here? From there till, say, somewhere here is the muscle that's been cut. Now you can see the depression in the tunnel. Got it? Yeah. Once it contracts and relaxes, you can see. Yeah. Yeah, here we go. Way better. Yep. Going down more smoothly. Yep, good, good, good. For the sake of it. It's hard to tell, no? That's the problem now here. Let me see. Wait a second. We put some injection and see. It's definitely on the diagonal side, I'm pretty sure. We'll put a clip on that, but just want to see where we are out. Inject. Stop that. One thing to do is put something through this, like a guide wire or something. Leave it alone.
It's not able to find out where the hole is from the opposite side. Yeah, that way is that.
Because it's on the inferior side of pylorus, I think.
Might not be.
Yeah, no, it's just behind that. Cannot retroflex obviously here. Nah. Can't go. It would be somewhere bang on, right? This, you see here? This, I think it's probably not going to be visible because it's going to be on the back side of the pylorus and the bulb. Yeah. Question is, are we good to go or not? To my eyes, I felt it's fine and it's okay with the tunnel here. Where the hell is my mucor? Okay, so let's see. Yeah, everything's corresponding. Even the numbers seem to correspond here. So I'm debating whether, I may just do a wire technique to just see where the wire is coming from. Yeah, there. 6 o'clock there. Yeah, there you go. See there? That's another sort of convincing proof that we are at the pylorus now. In fact, it's in a way good that I know. Or the doubt you have. Let's see. Let me see if I can move that scope. Yep. So that confirms that we are at pylorus. Flip here. Hold the scope. So it's just like that one judgment call. I was just like, let me just do that, just that little bit, and then I felt that, but I didn't do a lot of submucosal injections. So at one, so yeah, that's okay. No. Is she awake? Okay, not a great time for her to be awake. Whoops. Open. Not the easiest area to clip also. And it's a thin wall, so be very careful. You don't want to do needle induced, clip induced trauma also. Close, deploy. I assume that did it. Okay, fine. We'll see. Yeah. So I burned my hands in the past by trying to do that extra bit of myotomy, and I think we're done. Yeah, it's closed. It's approximated. The point that we can't see. No, great, it's open now. Where's the clip then? Okay, we'll find. It just took a little distal part. Never mind, we'll fix it. But I think the point is, are we okay with the pyloromyotomy? And I think it's okay. I'm not going to take care of that because it's more on the duodenal side. And this is all good here. And we have to now close everything. Good. Give me one more clip. Yeah, got it, but it's slightly distant. Okay. It's really a matter of, it's not the space constraint, it's just that lesions are, a bit of a problematic location there. Sure. Close. Open. Yeah, it's open. Close. Open. Close. Let it go, let it go, let it go. Yeah, mucosotomy, G junction, these are like hard places, Fix it. Open. Close. Oh, come on, man. It seems like it's right there, but now I can't see it. Yeah.
You should try to put it in the other direction like this.
That's probably what I want to do now.
Okay.
Is I want to get it like across the pylorus, turn it like 8 o'clock to 2 o'clock open.
Yeah.
That may be better because it'll grasp the tissue. 8 o'clock to 2 o'clock. Please move. Yes, good, better. Yeah, this is better. Except that I need to know getting it now. Close. Too much angle. Fix it, please. Angle. Okay. Close. No, again. Clockwise, start. Clockwise. Stop, close. No, again. More like 9. Okay. Stop, close. Yes, thank you. Okay. Open. Yes. Close. Such a teeny hole, that thing. All right, open. No, no. Close, track clockwise, yeah. Yeah, yeah, yeah. All right, okay. Okay, fine, that's good. Ah, yes, okay, no, ah. Stop, let the contraction go. Open. Oh, no. Okay, close. Yes, deploy. See, it's a micro, anyway. It's a micro one. Difficult to find it, right? Yeah. Oh, there you go. Let's do a barium, but yeah, that seems like it did it. Yep, you're right. Angle is the key. Okay, let's close it now. Regular clip now, please. Yeah, this. Regular clip, yes. Yeah, I think we need to try something else for the closure of these. You know, like a loop to approximate these edges would be. No, the loop would be a good idea. I think I'm thinking of anything. What's it? Yeah, 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 it's open. G poem is a problem, no, with the open. Yeah, yeah, yeah. Full open.
Correcting too much, right? The psoriasis is very micro.
It's the same situation when you are treating, you have to treat like a small vessel and you close it like this. Like it's always really difficult to find the part that's very small. After what is bleeding. When there is, yeah, small part that is inside the outer and you are not sure it's
So this is the problem. Is obviously it's a thick layer, right? Mucosa is very thick, so that becomes a challenge. It's like an edematous mucosa in a esophageal poem. Open when it comes to this. So close.
not considering the cost and like thinking that like the over the scope leaf can be easily removed
Open.
would be an option.
Yeah, close. Deploy. What was that?
Over the scope clip for closing this kind of.
OTSC. No. I mean, I think you could. Yeah, I mean, I don't know about easily remove. I have not done that, but we are going to do a couple of patients of cutters to remove these clips.
They should be easily removed. Like they went.
OTSC. Yeah, there's a cutter. You have to use that.
A specific, place where
Specific
you
cutter.
You're gonna,
You can do regular.
Like, Audiovesco is like just no audio.
Problem, cost का
The specific one is just
हाँ but ठीक है, then it's okay. It's fine, it's open. Tell them.
You're gonna destroy it.
Close. Yeah, no. I want that clip to be out of my cap. If I could. There's a talk on dead space as well. So like this instance, no, give me a better angle now, please. Yeah, give me like 8 o'clock, 2 o'clock. Yeah, open. Come on. No, not too much. Less. Yes, less a little. Let's stop. Oh, stop. Okay. Open. Good. Yes, better. So part issue is it's a little lateral, this incision here. And I'm gonna wait for the contraction to help me here. Maybe suction. Yep. Close. Yes, nicely deploy that. Okay, now it's got one lateral side. It's okay. Give me smaller clips now. Let's see. I think we should be okay. The big clips have helped us with the orientation now. A little on the right. It's okay. I'm gonna get a smaller clip to help that. Open. A little more. No. Yeah, it's fine, but this, somehow this is just. Yeah, stop. Yep. Perfect, but it's. So I need to find those little innovative methods with strings and, closure techniques to help with the closure in these cases. Which I've not done that. We should try it out next time. Yeah, I gave a full thickness one, but the other talk that Zahir gave was more and different tools that you can. Oh, counterclockwise, please. No. I want. Yeah. Perfect. Okay, that's great. Perfect. I like that. Close. Deploy. Okay, it's good. Okay, fine. It's okay. You got it. Do a little more on the left, and then this flip here. Standard. No, standard. But I think, we started and then I feel like the entry is just half a centimeter on the right than I would have wanted. Yeah, I mean, we could manage it open. Even from here, it's technically looks okay, but I had to do a slight change. No. Other way. No. Stop. Yes, that's it. Lovely. Close. Wait. Close. Bye. Fax is off right now. Yeah, it's just that, it keeps getting it on this. It's okay, it's got it, but can be better. Okay, couple of, at least 3 more clips and then done. Let's get the cysto ready, huh? Open. Not liking the angles. She's giving the perfectly wrong angles today, but stop. That's it. We're out with this. Yeah, the part of the issue now is that. Come on. Left, close, deploy. I'm just going with my gut feeling. In that case, get the left side. Did it get it? Yes, it did. Hey. All right, 2 more.
Maybe like a bigger one could be.
Yes, but we already used 4 expensive ones.
It's so
These are more expensive though, the mucosotomy and the first 2 ones. That's why I've switched to the cheaper ones now, because the bill goes up for the patient. Right? Open. System. Yeah. Open. Yep, very nice. Close. Lovely deploy, yes. Come on, yes. Nice, I like it. Yeah, 1 more and then we're done. This This is a little problematic with these closures sometimes when there's too much edema. Just
Okay, so
very
every
annoying.
time it's like
It's like this is esophageal poem is fine. The gastric poem you have to find a separate different technique. Maybe use the strings to approximate the two the
the
two
sides.
sides. So there is a way to it. I'll have to see. Open. You do a little loop. You attach it to the to the clip and then apply it one side.
Yeah, we did last time with no.
Now close, deploy. For the most part, this should be okay. It's very well approximated. But give me one more and to make it look good. Yeah, one more. All right, cool.